Hello and welcome to our webinar introducing the Clinical Resource TeleNurse model. Very excited. We had many people register. I think generally the audience is on mute, but please use that question field and type your questions. We want it to definitely be very interactive. Before I introduce our panelists today, I'll just kind of put this session 2 in the Virtual Nursing 101 series into context and kind of talk about overview of the different types of virtual care models that we have been talking about and where we're going to zero it in today. So on the next slide there, as I'll wait till we advance slides. What is virtual care? We'll talk through, I think many are familiar with the virtual sitting that AvaSure provides. In this learning series is really focused in on virtual nursing. And there are 2 main models emerging initially around virtual nursing. And one of them that we'll be zeroing in on today is the Clinical Resource Virtual Nurse model. And then in June, we'll be focusing on that expert oversight virtual nurse model, which is kind of illustrated and described in the middle here, where one virtual nurse is kind of doing a surveillance on a cohort of patients, often kind of like a virtual ICU model. So looking forward to that. That's number 4 in our series. But and last month, we talked about the competencies of a virtual nurse, and I had a great conversation with the CEO, Terry Hinckley, of the Academy of Med-Surg Nurses, as they are finishing up their certification and really defining the domains and skills and knowledge needed for a virtual nurse in the med-surg setting. And this Clinical Resource TeleNurse model is more focused on the med-surg setting, and that virtual nurse helps out a lot with documentation around admission and discharge and patient education, and providing more time back to the bedside nurse. And so how that model works is more of a, instead of that expert oversight, a whole cohort of patients, that virtual nurse is interacting with one patient at a time. And whether that's a mobile 2-way device or a fixed device in every room, he or she can help assist for an episode of care. And I like this kind of illustration where that virtual nurse is on the left. Right now, she's interacting with patient number 1, maybe doing some admission forms, and then she's ready to move on to other patients and really assist the bedside staff. So excited for this conversation. And let me introduce our panelists. So first we have Laura Gartner. She just finished her DNP. Congratulations, less than 6 months ago, I think. Also a certified nurse, executive, advanced and master's and nurse. And her title is Director of Clinical Informatics at Jefferson Health. So she's the Divisional Director of Clinical Informatics at Jefferson, Abington in Pennsylvania. She's been a nurse for 19 years after beginning her career in the medical ICU. Before we started the broadcast, Wayde, Laura, and I were all reminiscing because we're all former ICU nurses. And Laura accepted a position in informatics in 2013 and was promoted to the director level in 2020. And what we were just remarking on is she has continued a per diem role as a rapid response nurse throughout all that time, and has been doing that, did you say, over 9 years on the rapid response side? Yeah.
10 years.
Yeah, okay, and congratulations on your DNP, and lives in Philadelphia with her husband and 3 children. And Laura's passion is to streamline workflows in her nursing and clinical for her nursing and clinical colleagues, so they can spend more time focusing on the important things. And that's what we'll be talking about definitely today. And Wayde also Nurse Executive Advanced board certified, and patient services manager in the neurosurgical ICU in virtual nursing at UNC Rex, and special respiratory isolation unit. And he's been in his current role for 3 years and a nurse for 8 years, and has always been a part of leadership. He's overseeing the growth of the virtual nursing program, which over the last 8 months has grown from 4 core virtual nurses to 9, offering 24-hour coverage and performing 60 virtual nursing sessions a day hospital-wide. And his goal is for the virtual nursing program is continuous growth, utilizing technologies that provides a seamless, positive experience for the unit nurses and patients alike. And so after you did talk a little bit on our last webinar, Wayde, and so we were all wondering where you were from. And so now we know. One fun fact about Wayde is that he grew up in rural Australia and is excited to be vacationing there this year, and he's the unofficial tourism ambassador for Australia. So great, welcome both of you. And I think we're gonna just do a quick poll before we kind of dive in and have you guys describe your program. So on the audience poll, we know that buy-in is key to success of a virtual nursing program and critical success. So just curious, from your experience, which group do you think is most important? Is it the nurse managers? Is it the frontline nurses? Is it nursing at the administrative level, or is it that sort of that in between frontline nurse leader, the team nurse leaders and assistant nurse manager? And I'm going to throw charge nurses into that kind of frontline nurse leader category. And we'll see where our audience falls on what buy-in is most important. I don't think there's a right or wrong answer, but okay. And where's that coming out? I'm not getting the results yet. Okay. Okay. So it's those, and I think we're going to have interesting conversations about the clinical nurses and what they love about it, what they're embracing, what some of the barriers are. And then it's that kind of that frontline nurse leader day-to-day that is second most important. Very interesting. Wayde and Laura, would you, with your experience, would you agree or challenge those results? I'm just curious.
Well, for myself, I would both agree and perhaps challenge just a little bit. In our experience, you can get 1 or 2 frontline nurses at a time interested in virtual nursing, and then that'll sort of be a domino effect to the other nurses. But on one of our highest performing units, it's an orthopedic floor that does a lot of same-day discharges, and their team leader, right from day one, saw the value in virtual nursing. And just recently, she was able to drive the team to do 100% of their admissions and discharges over the course of a 12-hour shift virtually. So in my mind, having somebody in a position of leadership on the floor driving the buy-in for virtual nursing has definitely been very helpful for us.
Kind of that first level of nursing leadership, that's the closest. What are your thoughts, Laura?
I agree that the unit level leadership, we have a very engaged charge nurse who's been very instrumental in moving things forward. And I think it's kind of a tough one because each of those roles has played such a key part in our program. But where we are now, because we're so at the beginning, I do want to throw out there the nurse administrators have done quite a bit to help get the program on everyone's radars for budgeting, just support in general. In today's healthcare, it's really important that we get some of that support to move things forward. But everyone, I mean, I wholeheartedly agree that frontline nurses are critical because if it's not helpful to them, then they're not going to engage with it. And that's also, that's why we're doing it, is to help them help our patients.
Yeah, I mean, both of you talked about that in your bios. Is one of your top goals is really to help serve that frontline nurse leader. So Laura, I'll start with you, and if you could tell the story a little bit about how you and when you started virtual nursing, that clinical resource model at Jefferson, and the setting and kind of the model that you've started with.
So we are very new in our virtual nurse journey. We started a pilot at the beginning of March. The catalyst, virtual nursing has been on our radar for a little while. It's just an alternative care model for our staff. So not only to help us continue taking good care of our patients, but to help take care of our nursing staff, offload some of the burden they have, make it so they can spend more time doing things with the patients that matter. And as well as have another nurse, do things with the patient that also matters. So some of this administrative stuff. This particular pilot, though, kicked off in the late fall because we were anticipating a pediatric surge due to RSV, COVID, and the flu. And so we had this opportunity to pilot. We have 23 pediatric beds, hence the 23 cameras we have. And we got things moving with that. So we initially engaged with those units. And then thankfully, for the pediatric sake, we didn't have a pediatric surge like we expected. And so we took that opportunity to pivot to a med-surg unit, or 2 med-surg units. It's their sister unit, same manager, same staff. Primarily, they take care of observation patient class patients, but they do have inpatients on their units as well. So we had to get some approval from the Department of Health, which took a little bit of time. We had to recruit some nurses, and since we were recruiting for a PEDS pilot, we had to find nurses in our health system that had pediatrics experience as well as adult experience. And we're dual licensed since our health system expands over 2 states. So I will tell you that that's a little bit of a unicorn of nursing, having dual licensure as well as peds and adult experience. But we were fortunate to find two great individuals, and we got started in March.
And I just wanted to clarify that those 2 nursing units, although they're sister units, they're not in the same building.
They are not. They're actually in 2 different buildings. So we are a 600-bed hospital, and they are in one building over here and one across. But they have a charge nurse when she's out of an assignment that goes back and forth between the 2, and the manager has been fantastic.
Yeah.
And then I think the things you had asked about the model is we are focused on admissions, discharges, and purposeful rounding. That's been our biggest focus because it's an observation unit. We are starting to look and see how we can kind of move people through the system a bit faster.
And then the one other piece that I think will be important as you are looking at outcomes, and 2 months in is pretty early to be looking at outcomes, but certainly are tracking that it kind of worked out that you have 100% coverage on one unit and 50% coverage on the other. So you have this built-in control group of patients.
Yes, one of the building is a 12-bed unit, and all 12 beds have a camera assigned to them. And the other unit is 39 beds, and 11 of those beds have a camera assigned.
So the latent nurse scientist in me loves that model. So it won't only be just kind of pre and post data, that you'll have an intervention and control group, which is kind of cool. And it's interesting that it started with a crisis, and then we kind of switched gears, and it just took that impetus of the RSV surge, and now it's for adults, but we had already put a lot of work into it, and why not move forward?
Never let a good crisis go to waste. So this was a really good opportunity to see what we could do with virtual nursing at our organization.
Yeah, thanks, Laura. Wayde, can you kind of describe the origins of your virtual nurse program and how long it's been underway, and the setting and kind of the model?
Sure, absolutely. We have been going just a little bit longer. We are also very lucky to have an administration and an executive team that is fully in support of taking care of our frontline nurses. So that was really the genesis for virtual nursing. It was to provide support for the bedside nurses, but at the same time, like a split goal was to try to improve throughput. At the time, we were experiencing, as everyone does, some throughput issues, but that was leading to some holding in the ED, which nobody wants. So we thought virtual nursing might free up some time for the unit-based nurses to not only have more time for themselves, to take their breaks, to go home early, or on time, I should say, but also to have more time to do the things that nurses like to do, which is patient care. It's hands-on. And we understood that, well, we promoted virtual nursing as a real REX-based nurse. They are in the satellite building on premises, who's been here for a long time, but who can do anything the unit nurse can do on a keyboard or a phone. So if we get a direct admit and the facility doesn't send the chart, the unit nurse would have to call the facility, wait for the fax to come, call back, the phone is busy. That 45 minutes now we absorb and the unit nurse gets it back. If we go through a medication history, we can do that as well. But primarily admissions and discharges. We started off, the pilot launched on August 9th of last year, but we'd been planning since January of 2022 to do that. We originally had 4 core nurses. We started them 1 week at a time. So we trained 1 nurse and we launched on 1 floor. Next week we did 2 nurses and 2 floors. After a month, we were on about 6 floors with 4 nurses up and running. And right now we have 9 nurses. It's a total of 7.0 FTEs. And we had to borrow those FTEs. We're still working on the budget aspect. But that's allowed us to do, and we'll talk more about the growth of the program, but it's allowed for organic growth and spread throughout the hospital. And we're saving hundreds of hours for our unit nurses now through virtual nursing. And I have so much more to say, but I want to pace it out. So.
Yeah, exactly. And I think when you said borrow, I believe you had some budgeted FTEs that were vacant.
So yeah,
so
we've had to. It's a zero budget approach. So we, other than the cost of a few computers and headsets, we're using an overhead cost center. But the nurses their FTEs stay affiliated with their home units. They're all REX nurses, and the units they came from, we tried to spread the herd. They all had open positions, so it wasn't hurting their ability to hire. And we were trying to offset the loss of those nurses through the time saved to the virtual nurses, to offloading some of that work. And the balance kind of fell into place.
Yeah. Good. And both, so you're 8 months in, Laura's 2 months in, and I'm looking forward to reconvening in a year and seeing how you've really baked it in. And so I think that's where we're at with virtual nursing, and that's fine, and we'll learn and figure out how it can be sustainable. And I think you both kind of talked about the types of nurses that and criteria used for recruiting. So I'm going to shift to an audience poll here before we have a reveal on the interventions that are being done by the virtual nurses, both at Jefferson and UNC Rex. And so the polling question is, what would you guess would be the most frequent type of virtual nurse interaction? Would it be admissions, discharges, scribing, rounding, or patient education? And we're limited by GoToMeeting because I'm sure it's kind of like everybody wants to pick their top 2 or 3. But if you had to pick one and you're going to guess when we show the data from both of our guests, what do you think it has ended up being the most frequent type of virtual nurse interaction? And we'll give that just a little more time for people to answer before we show what we're finding, both at the AvaSure level, aggregated, and from Wayde and Laura. All right, let's see. Drum roll results. Ooh, they guessed right. So, well, I think we'll show you. But so number 1, admissions. Number 2, patient education. Number 3, discharges. But I think, honestly, patient education is such a big part of discharge. So that's kind of deceiving. You probably could combine those 2 in scribing and rounding. So Okay, well, I'm going to start with showing from AvaSure. We have multiple sites that are doing virtual nursing in this model. So I'm going to start with kind of showing the aggregated data that we have from the last couple of months. And those of you that are familiar with telesitter, we have Orna data on telesitter solution. And so we're building that for virtual nursing as well. So and this might be skewed by a smaller sample size, definitely, than we have in the telesitter solution. But virtual nursing has been a more common reason than the others for virtual nursing visits so far. And then purposeful rounding, and then discharge, and some other reasons. And I'll let Laura talk about some of the other reasons that they're seeing. But before I move on to that, let's show UNC's data, how you are seeing that, Wade, and you can kind of talk through and provide color on why you think this is. So much heavier on admissions than discharges for your organization.
Yeah, which I think you can expect because like Laura was saying, as we were chatting earlier, the documentation burden on admissions is just so much greater. And the nurses are often happier to hand that task off. There was some pushback about, well, that's how I learn the most about my patient. How am I going to learn about the patient that's coming in?
Yeah.
But we're to supplement care, not replace your care, and we encourage you to ask all the questions of your patient that you normally would. So we have seen a much higher volume of admissions as anticipated. The numbers to date in April are showing much higher, around 40% discharges to admissions, and without having
that's changing, evolving.
It is. We're seeing, and we started off at about 22% once we started tracking this. So every month we've gotten a little bit better in our percentage of discharge to admission, and I do wonder if that's a factor of the nurses becoming more comfortable knowing that we're there to support the admission as it arrives. So not only can we provide that comprehensive, uninterrupted, one-to-one discharge teaching that the unit nurses simply don't have time for, and that the patients love. We take care of the admission that's going to backfill that bed. A story I love, a charge nurse was telling me, she was telling a nurse that she's about to get an admission from the ED and her shoulders slumped and she groaned, and then she said, but virtual nursing has done the admission already. She said, oh, that's great. Bring it on, I'm ready. And that's a real win for us, because that shows that we're achieving what we set out to do, which is make the nurse's job much easier. So it's a difficult job, and anything we can do to help is worthwhile.
Right, and I have been surprised at this because in my mind, one of the goals is patient flow for everyone, and having patients holding in the ED is good for no one, especially not for the patients. And in order to unblock flow, you have to start with discharges. So in my mind, I was thinking it would make more sense to really focus on discharges first, so you can kind of provide the space for admissions. But in reality, just kind of how the workflows go, it seems like the initial buy-in starts with admissions. Laura, what has your experience been around this same type of?
Similar in the sense that we do more admissions than discharges. The admission paperwork getting done by the virtual nurse has been a huge satisfier. Even though it's an observation unit, they are doing all the same documentation that an inpatient nurse is doing. So there's a lot of questions for regulatory and things along those lines. We did get some feedback that the discharges, that sometimes the bedside nurses feel they can do them faster. So they're reluctant to reach out to the virtual nurse. However, like you said, with flow, it's very important. So we have been working with our virtual nurses to get them to proactively reach out to the bedside nurse to say, you have a discharge this afternoon. What time can I meet with Mrs. Smith to go over her discharge instructions and teach her her discharge?
That makes a lot of sense.
I think one of the big benefits of us performing all those admissions is the amount of data that we can collect that in the long term ultimately helps our patients. We're not just getting the required documentation checkboxes, those highlighted yellow fields in Epic. We go top to bottom until every box is completed or the patient begs us to stop. It's enough. All those social determinants of health, the community care aspects of the admission, and that helps us start impacting throughput by preparing for discharge as it's happening. We're mentioning the bedside binders and, your anticipated discharge. I know you're only being admitted would be 2 days from now, setting the framing in the patient's mind to prepare for that discharge on the day they're admitted.
And I don't know if this means anything, but I think both of you have high utilization on nursing care units that have very short lengths of stay. And so the discharge does start with the admission for sure on the OBS unit and on, like you said, your orthopedic same day. What unit was that has a very short length of stay, Wayde, that has great buy-in?
6 West, and they'll discharge 8, sometimes 10 same day orthopedic surgeries in one shift. Yeah, so it might be, I don't know if that's a takeaway for those on the webinar, but maybe if you're starting to start with a care unit that has a high ADT volume. Absolutely, yeah. High turnaround.
Yeah. Laura, can you talk a little bit about the rounding that your virtual nurses are doing and what's part of that?
Our cameras they're stationary in a room, so their nurses aren't taking them in and out. So that provided the opportunity for virtual nurses to do some of our hourly rounding. And between the admissions and discharges, we've started them off with rounding 3 times a day. So the bedside nurse would do the rounding the other hours, but 10, 2, and 6 or what have you, the virtual nurse is doing the rounding. And this, they buzz into the room and ask your usual rounding questions. You're having any pain? Is there anything you need? They can do a visual sweep of the room to make sure there's no hazards or tripping hazards or things in the way. And then they can save some time for that bedside nurse, because if they find out that Mrs. Smith is in pain, they can, ping the bedside nurse and tell her, like, hey, Mrs. Smith needs some of the morphine that she has ordered or what have you, so that the nurse can just bring that right in.
And in the other category, I think at Abington, there was a special MRI form.
We have a pretty lengthy MRI checklist, and so that has been we've had a lot of push to use the MRI checklist that's electronic, and that's coincided nicely with this project. So the virtual nurses have been very instrumental in getting us up and running with the electronic checklist. That's the majority of their others.
It's the MRI checklist, and I'm back. It's been a while since I was doing bedside nursing, but I would have loved for someone else to do my MRI checklist for me. And I'm sure radiology likes it too. So I think that was a great, maybe unexpected use case.
Mm-hmm.
So not as much scribing or specific patient education that was outside of admission and discharge is what I'm hearing.
Subscribing something that I'm very excited about, because it would help reduce some of the documentation burden for nurses. But we're so this week and next week we're working with part of my team is working with the virtual nurse and the bedside nurse together to get them in to see how it goes. So I don't think it's commonplace for a nurse to say her assessment out loud, just like it might not be common anymore for a nurse to write down, translate what's being said out loud into the flow sheets that we have. So we really would like to get that up and running, and then admissions would be even more streamlined, because if you just started right off the bat them doing the admission together, and then the virtual nurse could finish with all the admission questions and things along those lines, then I think it would help with patient flow and staff satisfaction as well as patient satisfaction.
So that might be a future. Okay, and then before we move on, Wayde, you said something before we started the broadcast about electronic, that button within Epic on discharge that you can say that the discharge instructions were given electronically. I think that's huge. Can you explain that for all our attendees?
I'd love to. And before I do it, that's just one example of why virtual nursing is so exciting, because the use case that you imagined and then what you will actually develop as people come to you and say, have you tried this? Have you thought about this? We've identified this problem. Can we fix that? It's led to us to expanding to PACU. We do same-day discharges out of the PACU now. Medication histories in the ED on patients who are not even admitted to capture that data. But the virtual nurses who are doing these dedicated admission sessions for 12-hour shifts at a time have identified a lot of redundancy in Epic, which we're working to remove, which will impact the whole system, not just our facility. One of the most exciting leaps that we just made, and it took a long time to get it to happen, but we've been able to remove the mandatory printing of after visit summaries to hand out to patients. It saves us something like $18,000 a year in paper alone, not to mention all the back and forth and the cumulative time that we spend delivering paperwork that sometimes people aren't even going to look at it. It's going to float around in their car for a week, you know. So now we can send that electronically through, we use my UNC chart, and the nurse can check a box saying that the patient consented to that, and then we move forward. Now, it's still optional to print that paperwork if the patient requests it, or if they have a particularly complicated discharge teaching that needs to happen. But overall, that's a big burden.
Something just happened there, but
Hopefully.
maybe you're better now. There is, before we move on, there was a good pertinent question typed in the chat that I'm going to throw out there now. I think this is key. How do the virtual nurses communicate with bedside nurses? And maybe I'll start with you, Laura, because I'm afraid to unmute Wayde. We'll see.
So we have several different mechanisms of the virtual nurses communicating with the bedside nurse, and we also have an algorithm too, in terms of, you know, if you do this and this doesn't, you can't get a hold of someone, that will escalate up. But the primary communication mechanism right now is a secure text message through our electronic health record.
Okay.
And then we also have the nurse leaders on the bedside unit are sending messages with the plan for the day, the round information from the huddle in the morning via secure chat. And then we also are working on some tasks that we're adding to our electronic health records so that the bedside nurse can assign something to the virtual nurse, and then the virtual nurse can see that on her side of things on the electronic health record and then do them accordingly.
Oh, that's really cool. Are you nodding your head, Wayde? Is that similar for you?
We are similar in that we also use secure chat as the primary form of communication. The virtual nurses all have desk phones, but we don't publicize those numbers. But the thing we're doing a little bit different on night shift is we do give the night shift virtual nurses a mobile phone, and we've distributed that number widely, and we're marketing that team as a phone a friend. So we understand there are a lot of new grads on night shift. Often the nurse is not available to help them. We can help them write SBARs before they call a doctor. We can, you know, give them advice. Our nurses have a combined 200 years experience in nursing, which is just mind-blowing, really. But those nurses have only started within this month, but rather than be based at the desk like the day shift nurses are, they round a lot more, introduce themselves, who are new grads, I want to be their friend, that sort of thing.
And I haven't had the pleasure of visiting your Abington yet, Laura, but I did get to visit the virtual nurses at UNC Rex, and they are just wonderful. And they said that too. I just met 4, and they said between us we have 100 years of experience. And also I liked what they said, that they give off the vibe, I think, that they're not busy to their patients as they're interacting with them, and that's why they're able to do more thorough assessments. And I think they must have really gotten good at developing website manner. And so this is a little money trail, but I'm really excited, Wayde, that you are participating with the Academy of Med-Surg Nurses on helping to write some of the questions for the virtual nurse certification that's coming out. So, and part of that is the website manner and the experience and creating that rapport for the phone a friend. And we are answering without actually me saying it, we're answering one of the questions that got put in the in our chat. How do you build rapport and trust between virtual nurses and the bedside team? So do you have anything to add to answer that question besides what we just talked about, Wayde?
Good barometer for all of our virtual nurses was that they all said, I'm not sure about this, I'm going to miss the patients. I love talking to patients. And they get more of that. That's all they get to do. And they don't have the vocera or the phone, the call bells. And not only do they love that, the patients, particularly when we're doing admission sessions in the ED, they really feel like the course of the progression of their hospital course is moving forward. Finally, I can talk to somebody. I have this question. I need to know this. When is this happening? And most of that we're able to figure out through the chart and help the patient navigate the pre-bed hospital setting in the ED. So the mood booster for patients.
I love that when you're interviewing and someone says, I'm not sure I want to do this because I'm going to miss patients, then you're like, yes, we definitely want to hire you now.
Exactly.
Versus, I'm sick of patients, let me work from home. So that's, and Laura, do you have anything to add on the building the rapport?
No, but I think that you called out something really great there about how they're giving off the vibe that they're not busy or they're not as busy. They don't have a vocera ringing, interrupting them while they're talking to the patient. That's great.
Yeah,
that's something we're still learning.
Less interruptions. So I think we were going to shift on some of the data that we've collected to also talk about how many interactions the virtual nurse is. Oh, before I do that, I just kind of wanted to share this interesting, and before we get off kind of that admission and discharge piece, and within our data, our aggregated data at AvaSure, we're looking at time of day. And so I think we're gonna shift into planning for coverage and staffing and how much can a virtual nurse do. And so this will grow, but I kind of like to see the trends of time of day for when discharges happen and when admissions happen throughout the day. And you would expect that those discharges are happening in the morning and early afternoon, and then the admissions come in after that as the beds empty out, which is kind of what we're seeing here on from aggregated data from multiple hospitals. And also, I think they've got that little kind of outlier at 7 in the morning, and I think that might be just when the virtual nurse starts. Then they're able to kind of catch up maybe on some admissions that may have just happened. But then that flow of let's do some discharges so we're ready to do admissions in the afternoon. And then I think on the next slide, we have AvaSure data about, and this is emerging, and I think many of these organizations are still sort of on their learning curve, but you know, how many interactions can a virtual nurse do? I think this is a big question out there. We don't, and it really depends, but just ballparking, we looked at the 7 to 3 shift, and on average, a virtual nurse was doing about 10 interactions with patients during an 8-hour shift there. And then that same 3 to 11, it's an 8-hour shift, they're doing a little more interactions. And then I think, Wayde, you were generous to send some data from on the next slide about your utilization just month over month. And so I'm wondering if we can just talk about help those that are on the line that are in the planning phase, like how much can a virtual nurse cover? Or do you want to first talk through what this graph is telling us, and then any advice that you could give those that are on the call about planning for coverage?
Happy to. It's one of my favorite graphs ever. So this just shows our total sessions completed virtually for the months since we started in August of last year. In April, I just looked this morning, we've exceeded that number already. So we have had steady growth and buy-in. One of the challenges we started with was it was a tough sell to get people to come to a brand new program. The virtual nurses, they were going to miss their patients. They love their 212s or their 312s. They weren't interested in working 5 days a week. So we compromised and said, okay, we'll go 7 to 7, keep your schedules. And we thought to keep them productive, we'll have them doing audits, restraint audits, chart audits, or all of this sort of back channel support of the nursing units, which we didn't end up having time to do. So what we did instead, our facilities policy is that you have 24 hours to complete an admission, and just giving people, the unit-based nurses, the okay and permission to put an admission on our board at 11 o'clock at night, knowing that we're going to do that at 7:30 in the morning once we get set up. That was a tough sell. A lot of nurses were fearful of the eyebrow raise at shift change. The admission's not done. No, the virtual nurse is going to do it. That's okay. And once we got that sort of rolling a little bit, then we would come to work as virtual nurses at 7 o'clock in the morning and have 7, 8 discharge admissions rather on the board ready to go. And we have all day to get to them if there's a family member not available or the pharmacy's not open yet. So that just sort of allowed for consistent work throughout the day. And then, as you saw on one of the previous graphs, once you get to lunchtime, and particularly after 3 p.m., the traffic really picks up. If I could do it again and I could convince my virtual nurses, we would probably staff like a 2 to 10 p.m. to start, maybe even 2 to 11.
Okay. How about you, Laura? How are you staffing and how many visits are they doing? Or?
So we are staffed 9A to 9P, 5 days a week, Monday to Friday. So we don't have overnight coverage right now. There's one virtual nurse working at a time for the 23 cameras. And since those cameras are stationed in specific rooms, sometimes that census will vary up and down based on if there's a patient there or not. In terms of how many connections or visits they can do in one day, it depends on what's going on in the unit. Like I said, we have them doing purposeful rounding 3 times a shift. However, there's patients that might be off the floor, what have you. So, but if we're doing 3 for 15 patients, we'd expect to see 45 sessions. But those are very quick versus an admission or discharge where you might spend a lot more time with the patient.
So more to be seen on that, but that's kind of helpful, I think, that one virtual nurse is covering 23 patient rooms for a 12-hour shift. And Wayde, you have a few FTEs at once, and you're kind of covering the whole hospital, or how many? Not every care unit, right?
So we're on basically every unit within Rex Main, which is 437 beds. And then we also cover our other Rex hospital in Holly Springs, which is much fewer beds, but we do a lot of work in the ED there. I'm very jealous of Laura's in-room setup, or we're using tablets at the moment. And I know AvaSure is going to help us pilot something, hopefully, potentially. My fingers are crossed.
Yeah.
Because we did have some technological barriers to overcome as well.
Yeah.
Which way?
That's what having a pilot is about. Yeah. Great. I think we're kind of talking through, we've naturally kind of gone on to the capacity of the virtual nurses, and I want to make sure I'm catching up. Yeah, okay. And then let's move on to outcomes that we are all tracking. And so thanks for sharing with us, Wayde, some of your key results that you've tracking, and you've been doing it longer. So would love to hear your voiceover on some of these results that you've gotten already.
Yeah, month over month, we've managed to save, roughly 30 12-hour shifts of computer time by our estimates for the unit-based nurses by taking all of those admission and discharges. We did see a correlated improvement in discharge satisfaction metrics with the implementation of virtual nursing. And we're working to, again, with that technology piece to really solidify that tracking and data gathering via automated email surveys and things like that to patients and nurses. One thing I know we're focused on med-surg at the moment that we did is move into the ICU and do those ICU admissions, because, you know, a critically ill patient has a lot of things to do before the nurse is going to start thinking about admission paperwork. And that's one of our success stories that, and I'll share now. I was going to save it for later, but
Go ahead.
we had a patient and we didn't get to the admission paperwork for 3 days until they transferred. They went to the floor, they did the admission paperwork, and the flag came up that this patient needed a nutrition consult. So had that admission been done virtually, we would have caught that on day 1 instead of day 3. And we've seen many examples since of things like that pop up, because our virtual nurses are empowered to order the consults that Epic flags, get in touch with any providers that we need to. Again, anything that the unit nurse would normally do on a keyboard or a telephone, we can do for them. Another efficiency, I think I mentioned already the Epic efficiencies we've noted, like duplicate charting in different areas of Epic that we're working to remove to make it a much more streamlined flow. We've been able to partner with our interpreter services department to have 3-way video chats. And that's a win for everybody, especially for the unit nurses who no longer have to coordinate that piece, but also for our in-house interpreters who don't have to traipse all over the hospital, then wait for the nurse, then wait for the patient's family member. They just beam into the video chat when it's ready to go. So there are many examples of things like that that have popped up, and we just sort of give it a go, and it's led to more growth and more adoption, and it's been really a good, fulfilling cycle.
Awesome. And Laura, how about you? What are some of the early outcomes that you're seeing?
Well, we are very new at this, so we don't have a ton of data yet, but we've seen positive trends in length of stay, as well as the discharge order to discharge time, so when they actually leave the building. Anecdotally, just like you said, Wade, we've had some really good feedback from patients and staff. Yeah, particularly staff. It's a huge satisfier for them to have that admission stuff done for them, or to feel like they don't have to do that. It makes them more likely to bring an admission up from the emergency department, knowing that they don't need to do that work. Because there is that eyebrow raise, a change of shift, right? When, oh, you haven't done the admission yet, even though we also have 24 hours to do it.
Yeah, and you feel guilty if you're a nurse and you're heading home and you haven't done that yet. And you feel frustrated if you come on and the previous nurse hasn't done that yet. So to really have that other resource for that is kind of a win all the way around. And then we're coming towards the end of the time. So let's talk about some lessons learned, and I'll start stick with you, Laura. What are some lessons that you've learned early on that might be helpful for those that are attending?
I think that a couple of important lessons are to be flexible. We're still learning as we go on, so rather than having a rigid process, taking the feedback from the nurses, taking the feedback from the patients, and using that to make the program better has been a very important lesson. I think, we've touched upon like some of the skills or what have you for a virtual nurse versus a bedside nurse, and that's, we're learning about what will make a great bedside nurse. Great virtual nurse, and we can use that as we continue to scale up. But I think the flexibility and just being open to change and learning are pretty key.
Right, and the bedside nurses have been forced to learn to do the bare minimum kind of, and as fast as they can, admission and discharge. So to kind of like shift that mindset as you're moving to virtual, that you can take a breath and you can dive a little deeper and get more thorough and engage with the patient is great. I think a great lesson to share. How about you, Wade? What are some of your top lessons learned?
I agree with Laura 100%. Just being flexible and knowing that everything you plan may not pan out, and there will be things that you were planning on that turn out to be some of your biggest wins. Just problem solving in general has been very helpful, and just being open to suggestions on workflow improvements. We sort of made it up as we went along, and our original 5 tries weren't right, so we just kept adapting until when we're still not there. I'm sure there's always room to improve.
Yeah.
I think other than that, just your regular change management processes, selling the why, building the trust in the team, because they can't see us. They don't know us necessarily, that we have 200 years of experience. They may not trust us. That's my patient. I'm going to do the discharge. Until they see a couple of the sessions in progress, because they'll be in the room doing something else and overhear the virtual nurse on the video session and take a breath of relief. Okay, these guys are good. But no, I just think overcoming that initial, getting that buy-in, it requires a lot of engagement, especially if you expand hospital-wide too fast. You don't spread yourself too thin, because I attended a lot of unit huddles, a lot of staff meetings. There's been many PowerPoint presentations, but just you have to get out there and amongst it for people to see that the program has value and value to them.
Yeah, and their patients. Do either of you have any specific stories to share, patient-centered or nurse stories that we haven't yet, before we go to questions?
I know Laura said that some of her most common pushback, as was mine, was I'll just do the discharge myself. It's faster, it's easier. And we really overcoming that message with, but is it better for your patient? Because we can spend that 25 minutes, we can do teach backs, we can go around in circles for 25, 30 minutes, and we don't have one foot out the door while we're charting something else. That's what the real benefit is to our patients. And then just once you just get them hooked on virtual nursing. So I got feedback from a nurse on Sunday, and we're not on Sundays currently. You don't realize how much you love virtual nursing until you're here on the weekend and they're not. And that just music to my ears. So
that's it. You want to get to the point where the bedside nurse is like, we can't live without this. Yeah. All right. Anything else to add, Laura, before I ask some questions? Okay. Great questions. They're really pouring in. So I'm going to start with a few kind of like easy ones. And this one I wanted to know. So how do you sign the after visit summary if you're not printing it? Does the patient have to sign it?
We had a button added in Epic. Patient consents to receiving AVS digitally.
Boom. Okay. Nice. That's
and then the virtual nurse will let it know, just like a unit nurse would in the chart. It says discharge complete by virtual nurse. No concerns. Patient has all belongings. Your usual stuff.
Okay. And here's kind of an easy question too, which I think we didn't talk about, is where are your virtual nurses physically located?
Ours are on campus. They're in a satellite building. We do that for internet connection reliability and security. But everyone who approaches me in the hallways who wants a job thinks we work from home and would love that. We're not there yet. We want to say we're at Regs. Yeah, we're on the hospital property.
Same with us. Our virtual nurses are on campus as well, off the unit, actually in a third building of our hospital, in a central location.
Okay.
Because I think a lot of programs admission discharge nurses, and they'll get pulled in to just drop this med. Can you help me turn this patient? We're staffing short today, but we want to avoid that.
And that's what I was just going to say too. Like having them physically in a different building is probably key to avoid just that exact thing. Just do this one thing. How about this? And it would be really hard to say no to that. Let's see. I had a couple other great questions here. Do the virtual nurses do much provider communication?
For us, very rarely, unless we discover there's big errors in the medication history and the reconciliation needs to be done over, then we'll just attach the provider into that secure chat. We'll loop them.
Okay. That makes sense. Yeah.
Although it's something we're working with our virtual nurses on, because they can reach out to the provider as well and then put the nurse on the chat.
Yeah, that's great. And when I was on the task force with the Academy of Med-Surg Nurses, they were talking about mentoring of newer nurses and kind of helping them and prepping them or coaching them through kind of the SBAR with the provider is a frequent phone a friend use case for bedside novice nurses as well. I'm trying to think if got 5 more minutes. Some of these are kind of in-depth questions. Somebody said, will this be recorded? Yes, it is recorded. And timeouts. Oh, that's interesting. Do the virtual nurses do medication checkouts or timeouts with providers for procedures? Those sounds like good ideas, but not yet. Okay. And then I think you talked about it a little, we talked about, I think let's just finish with this one last question. We talked a little bit about chat between, for information between the virtual nurse and the bedside nurse. Is there anything more in depth for like a handoff? And handoff from virtual nurse to virtual nurse? Or is it kind of episodic in the secure chat is enough of a handoff between bedside and virtual and then virtual to virtual?
Our virtual nurses don't back up to each other, so they can't give each other handoff because we're 9 to 9. So when they come in, it's
so it's either one or the other. Okay, yeah.
So they do not get handoff from each nurse. We do ask them to touch base with the charge nurse to get an overview of what's going on those 2 units for the day.
Okay, through the charge nurse is kind of how they get. Okay. Do you have anything different to add on that, Wayde?
Our night shift and day shift will hand off if they need to. This one is on the list, but family is working until 10 a.m., that sort of thing. We don't really hand off. If there's a discharge, we'll just get 5 minutes notice, and then we'll review the AVS, go through the charts. If we have any questions, we'll clarify with the primary nurse. But generally, there's not too much back and forth.
Okay. And I think we'll probably address that more in our June virtual nurse series when it is 24/7 expert oversight virtual nursing, and then they are handing off between their shifts as well as with the bedside.
So one thing I would add, when a new nurse does call the virtual nurse for advice on something, we do hand that interaction off to the education department, and then they follow up with the new nurse. Yeah.
Oh, that's great. That's great. Well, we're out of time and we could keep chatting, but thank you both so much. And thank you for your generosity to share what you've learned so that others can start a few steps ahead. And we must do something different in the way we're delivering care, just because simply cannot print enough nurses to cover what we need. And so the next sessions coming up, I think we have those to share. The next session is building the virtual nursing business case, and that is on May 25th. And we're trying to do this, I think the 4th Thursday of the month, so you can predict it over lunch on the East Coast. And looking forward to seeing people at AONL. If anybody happens to be going there, I will be, and AvaSure also has a booth there, so you can kind of do a little hands-on with it, the technology, if anybody is happening to come to AONL. And we've got a next webinar coming up May 18th, investing in nurse retention, how refreshing your hard work can help. So thank you, Wayde and Laura, and have a great rest of your day.
Thank you, Liz.
Yeah.